Okay. Well, I see we're at 11:01, so we're going to get started here. Welcome, everyone. So happy that you're joining us for the second of a series of 3 carbon clinics that's being sponsored by the National Academy of Medicine as part of the Action Collaborative on the Decarbonization of the U.S. healthcare system. We're really excited to bring this to you when we're here to talk about Carbon Clinic number 2, which is the second in a series of 3 carbon clinics. The intent of this series is to introduce healthcare and hospital systems, the concept of really managing carbon. And a foundational step in that is understanding what an organizational carbon footprint is. And so we are here in the second step of that process. And here we're going to focus on scope 3 carbon footprint, which includes purchased goods and services. That's everything the hospital buy, from pharmaceuticals, bandages, supplies, knee joints, capital goods, our transportation use, and then the use of our own sold products. This is the second in a series of 3. A couple weeks back, we had clinic number 1, which focused on scope 1 and 2, which covered scope 1 and 2 cover the usage essentially of energy and anesthetic gases and refrigerants on buildings that hospitals own and vehicles that they own. Scope 2 is focusing on those items. And then on January 26th, we'll cover the balance of scope 3, which is investments, employee commuting waste, business travel, leased assets, and carbon offsets. And I'm very happy today that we have 3 rock stars of the healthcare sustainability world. We have Matthew Eckelman from Northeast University, Beth Schenk from Providence, and Jody Sherman from Yale University and Yale New Haven Health Systems. They're here to share their stories, their understanding, to help arm you with the information to tackle this problem, which is a massive problem that, thankfully, excitingly, healthcare is really motivating and moving in massive fashion to start to address this much more systematically and comprehensively. And we're here to help push us a few steps down that road. The topics that we're going to cover today, one I've already covered, which is an overview of carbon clinics. Then Matthew is going to talk about sort of scope 3 and really get into the details of carbon accounting. He's going to kind of do his own section and talk about how scope 3 is calculated. It's done in different categories. He's going to present. He has extensive experience in this. And then at the end of his session, we're going to have a Q&A session. So in the degree to which carbon accounting is confusing, which it is for people that don't understand it, he is here to sort of illuminate and shine a bright light upon what it is, the data you need to collect, how it all works, and answer questions about it. After that, we're excited to share 2 kind of implementation case studies, one from the Providence Healthcare System given by Beth Schenk, the second by Jody Sherman from Yale New Haven Health System. At the end of their 2 presentations, we'll have a question and answer system. The way that we're going to do this is each of us is going to share our presentations. And as we transition, I'm going to have the privilege of introducing each of the speakers. So at this point, I'm going to stop sharing my slides and Matthew will start sharing his slides, and I'll get to introduce him to all of you. So happy to introduce Matthew Eckelman, who's a PhD and associate professor of civil and environmental engineering at Northeastern University. He also has an affiliated appointment at the Yale School of Public Health. And his research focuses on modeling emissions, life cycle impacts, and health damages from the healthcare sector. Perfectly appropriate to our topic today and quantifying the benefits, clinical products and processes for sustainability and collaborating directly with clinicians. He directs a life cycle laboratory at Northeastern University with funding from a variety of government agencies, including the EPA, NIH. He's a member of the Lancet Countdown on Health and Climate Change, has worked extensively with the UK National Health Service on developing their long-term strategies and plans for healthcare decarbonization. So nothing further from me. I'm happy to have Matthew. Please get started.
All right, thanks very much, John, and nice to be with you all today. Matt Eckelman, and as John mentioned, my job is to give some basic instruction around Scope 3, these categories that we're going to cover. And so I'll start off with a little prelude and jump right into it. So this is a picture, a graph that was made up by the National Health Service in the UK, describing the healthcare carbon footprint. And as you've all heard and are probably very well familiar with, there are these three scopes or groupings of emission sources. And as John mentioned, last time at Carbon Clinic 1, we focused on scopes 1 and 2. These are direct emissions from on-site and emissions from purchased energy, such as electricity or steam generation. And you can see over here, these are categories or scopes that are within healthcare organizations' control. They have some control over what kind of furnaces or boilers they use. They have control over the demand for electricity on site. What we'll focus on today is scope 3. These are more indirect emissions, and as such, they are much more complex and distributed, as we'll get into. So these indirect emissions in the value chain don't occur on site, and they don't even occur just one hop away, but all the way upstream and downstream in the value chain. So that can be pharmaceuticals, food, medical supplies, a whole host of products, also services like IT, cloud services, testing services, or even construction and facility management services. So this is really a large variety, and as such, it's a kind of intimidating part of carbon accounting. It's also the largest. So as a researcher, I do modeling around healthcare emissions, including in the United States at a national level and other countries and organizations around the world. And I just want to emphasize here that if we look at the total US healthcare emissions pie, you see scopes 1 and 2 up here in blue and red, and together they constitute about 20% of the total. The remaining 80%, right? So the great majority of healthcare related emissions is scope 3. It's in the supply chain or in the value chain, and that can be broken up into different contributors like food and pharmaceuticals and chemicals, and so on. But it's important to realize that this category or large group of scope 3 emissions is really essential. We have to struggle with it. We have to try to count it and reduce it if we're going to really get to net zero. This has been pretty consistent over time. So we've looked at emissions over the last decade or so. And yeah, you can see scope 3 has very consistently been the majority. Now, we are a bit exceptional when you compare different, mostly industrialized countries as to our per capita emissions. And so what I'm showing here is per capita greenhouse gas emissions on the x-axis. You can see the United States is far and away the largest in terms of our per capita emissions. And what I've done is plotted this against an index of healthcare access and quality. And I hope you notice that the US is not achieving a very high level of healthcare access and quality for the large quantity of emissions and expenditures that we're making. So what we're trying to do in all of this work is to both bring the US per capita emissions down and also improve healthcare access and quality as we improve healthcare service in general. Now, to motivate this work, of course, emissions are important because they cause greenhouse gas and radiative forcing and ultimately the global warming effects that we're all worried about. Rising temperatures, more extreme weather, rising sea levels, and so on. And these, in turn, have very direct effects on our health, both in the United States and all around the world. So this graph from the CDC is kind of the poster child graphic around why we should worry about the effects of healthcare, global warming, and greenhouse gas emissions in general. And this is a kind of qualitative description, but we can also quantify these effects, which is something we've been working on for some time. What you're seeing here is different scenarios of how climate change will play out. And on the y-axis is a measure of health damages, so-called disability-adjusted life years. So these are the emissions from the healthcare sector. And if we look at its health damages, you can see a couple 100,000 disability-adjusted life years lost from healthcare sector emissions. So these are health damages from the healthcare sector, but they're happening indirectly and mostly through these scope 3 emissions. So this is really a health issue, and this work that we're all doing together around decarbonization, the goal here is to also improve environmental quality and jointly human health. So with that bit of a prelude, I'm going to jump into the how of carbon accounting in scope 3, following very closely the greenhouse gas protocol, which I imagine you are all very familiar with. So this is the document we'll be following. There are 15 categories of scope 3 emissions. Some of them are focused upstream from the organization in question. And the categories in red are the ones that we're going to cover today. So purchased goods and services, which is the largest, capital goods, and upstream transportation and distribution. The third carbon clinic will cover the remainder of these. There are also downstream categories, and we'll cover 4 of those today. Also transportation and distribution, and the processing, use, and end of life of sold products. All right, so that's the plan. So let's jump into the first one, purchased goods and services. So I'm just quoting here. I think it's also always useful to look at definitions. This category includes all upstream cradle to gate, okay, and that's a really important note, cradle to gate emissions from the production of products purchased or acquired by the reporting company in the reporting year, including both goods and services. All right, so this is the largest and most complex category of scope 3 emissions. So this is the one that we'll spend the most time on today, at least from my side. And as you'll see, the greenhouse gas protocol, the standard for corporate or organizational scope 3 emissions, it gives several options. None of the options are perfect, and we'll look at different trade-offs. But what I want to emphasize here is that you can choose. You have agency about which method you go with. The standard isn't prescriptive in telling you exactly which method to use. So what I hope to do today is provide you some guidance and description of what you should think of when you're making this choice about what method to apply. All right, so we'll go through this in a few steps. The first step for me is always taking a look at what data we have. So this involves working with your procurement office, or maybe some of you are in the procurement office. All right, so digging in, finding this information, and if you have an experience similar to mine, yeah, it's pretty busy. There's a lot of possible procurement data you can get. You can get information by supplier, individual items, exactly when it was purchased, right? What you spent on it. So this kind of information, right? It can be large and intimidating to try to do something with for the first time. Okay. Why I recommend looking at your procurement data first is that it'll give you a sense of what you already know. And of course, collecting this isn't always so easy. You have to maybe run a report, or get your procurement colleagues to run a very large report for you. They might want to know exactly what kind of categories or products you're interested in. And when you say, I want to know all of them, right, that can be a kind of a big ask for them. What I want to just point out with this example is that in particular, we know both the number of units that came in, and we know the amount of money that was spent here. We have a text description of what was purchased, okay? But we don't have any information about the mass of each product, right? And we also don't exactly know what these products are being used for. And if you're a specialist and you're familiar with all these items, well, you can probably classify them yourself. But if you're an accountant and you're not that familiar with the clinical side, you would struggle to know exactly how to classify these different things. Okay, so having this view of what data are available is a really important first step, and really a prerequisite to the next step, which is what method to choose of accounting. So this is a graphic straight from the Scope 3 standard here, and you basically have 4 choices. So your first choice is called the supplier-specific method. And the data that you need is broken up into 2 pieces: supplier-specific data that's about their own operations, and supplier-specific data over here on the left that's specific to their own supply chain, right? So the idea here is you have one of those items in that list that I just showed you in the prior slide. You call up the supplier, you say, hey, I would like to know what's the carbon footprint of this thing I'm buying from you. And miraculously, they know both the carbon emissions from their own operations and the specific emissions from that product specific supply chain. Okay, and you need the mass of the product in order to actually pull this off. All right, so that's one example, one method option. The next option is very similar. You still call up your supplier, but instead of knowing exactly what the supply chain is for that specific product, maybe they only know, well, I'm using a little plastic and I'm not sure exactly where the plastic's coming from. So they're using some industry average in order to quantify emissions in their own supply chains. So it's this mix of specific information for their own operations and then average information in their own supply chains. And because we're merging these two, this is called the hybrid method. And this is very, very common. I will say the supplier-specific method is rare. It's very difficult for suppliers to actually do this unless they have a pretty homogeneous or short supply chain. Much more common is that when you call them up, they'll give you information according to the hybrid method. All right. The next option is called the average data method. In this case, you don't have time to call up all your suppliers. All you know is that you buy, let's say, 20 tons of the latex gloves, right? You might buy them for 30 different suppliers, and you just don't have the time to call them all up and get this supplier-specific information. So you use average data about latex gloves, both the manufacturing of the gloves and the supply chain of the latex. Okay, and then you apply that method again to the mass of gloves, or maybe the number of units of gloves that you have. Right, so that's option 3. And now the fourth option is called the spend-based method. And what makes this different is that instead of using the number of units or the mass of each product that you're buying in order to calculate carbon emissions or greenhouse gas emissions, now you're going to use your expenditures. And you also have the same kind of approach. You're going to use average data from supplying sectors and supplying upstream sectors as well. But you don't have to try to translate your purchase information into mass. Okay, there's a lot of benefits to that, and also some disadvantages that I'll go through. So these are your 4 options. I want to just take a little bit of a sideways slide here to just help you understand what's going on with these mass-based methods, the first 3 options that I showed you. These use engineering models. So your supplier will have information that they're taking off of their utility bills, or they will have a kind of engineering model of their process from the equipment that they're using and how much power it uses and so on. And we use those engineering models to determine the emissions in physical terms. And this happens in these 2 steps: the foreground information, where, for example, the materials that go into this electric kettle, the copper, the plastic, the aluminum, and so on, all of those materials we know are coming in the door, and we have information on how much energy it takes to put them together. And then with each of these materials, well, we follow each one up the supply chain. So in order to make copper, right, you have to mine copper ore and beneficiate it, extract it, and refine it, and so on. In each of these steps, we have a different engineering model to calculate emissions. So in these kinds of mass-based, or what we call life cycle assessment, process-based models, we're following the physical flows of emissions and just physical flows of information. The other option, the 4th option, the spend-based method, uses a totally different approach. Instead of using engineering models to understand how emissions form, we use economic models at a very large scale, a national scale, and then we combine that with some overall inventory information from the US EPA, again at a national. So in this case, we have our healthcare sector, right? Not the product, but we have a healthcare sector. That healthcare sector takes in goods and services from other sectors, and those sectors take in goods and services from other sectors, and on and on and on, all the way through the economy, until we get to sectors that actually cause a lot of the emissions directly. So these are their scope 1 emissions, things like power generation, agriculture, chemicals manufacturing. So these are 2 very different approaches to calculating carbon emissions.
Hi, Matt. I just wanted to let you know you're around 20 minutes.
Okay, thanks very much. So I think I'm going to cannibalize my own Q&A, but that's okay. So we have, if I line up these 2 different axes, if I think of accuracy on the y-axis here and speed or data availability or comprehensiveness on the x-axis, I just want to map out where these really fit. The supplier-specific option method, it's highly accurate, but it's very, very time-consuming. Yeah, and often it's hard to get in terms of data. The next method, hybrid, it also is time-consuming, right, and a little bit less accurate. The average data method, it's certainly less accurate than all of those, right? Maybe less representative of your individual products, but it's it can be a little bit more speedy. Whereas the spend-based method is the least accurate, but by far the fastest. Okay, so in choosing which ones to use, there are lots of different challenges here. First, it's often difficult to get the procurement data in the first place, and it's difficult to categorize the procurement data so that you can decide, well, all of these things that I'm looking at, all these records, these are all the gloves, and these are all the drugs, and so on. And then once you have that categorized, it's hard to translate it all into mass terms. Often that's impossible. A single supplier might provide hundreds of items which makes it difficult to call them up and get exactly product-specific information. And you might buy the same item for multiple people, so you have to make your own average. And you might change your mind halfway through the year and use a different supplier. I'll tell you from experience, often you call suppliers up, there's limited or just no information that they have to give you. Or if they do have information, it's very common, they only are tracking their own emissions and not their supply chains. Finally, remember, we're trying to count all goods and services, and services don't have mass. So those first three options about mass-based methods, those don't work at all. But on the other hand, if I use a spend-based method, I don't get any kind of reflection of green initiatives that are going on at my suppliers. So why don't I skip a few things here so I can catch up a little bit. So which modeling approach is best? I would say both mass-based and process-based are needed here. And the reason is that spend-based methods are comprehensive. You can count all goods and services and really get a full view of your emissions for reporting purposes, and also just identifying where the hotspots are. So this helps set strategy. Whereas process LCA information, those mass-based methods, those are really critical for making improvements or choosing among options and actually making progress towards decarbonization on the implementation side. So this was essentially the strategy of the National Health Service, which I had the pleasure of working with for some time. And they had both spend-based, kind of comprehensive top-down view of their emissions, and then they started looking bottom-up, looking at individual items of interest. So that's what I recommend to you all. Use a spend-based method to count everything. Use average data to count some large volume homogeneous items like paper, for example. And then once you have those things in place, then use your connections to your suppliers and reach out to get information on specific items of interest using the hybrid method. And over time, you'll get to use less of spend-based. You'll essentially replace your information about your emissions with better and better quality, more accurate information over time. All right, so let's say you take my advice and you go out and choose one of these methods. Now you have to find your emissions factor. Okay, so there are a couple of choices. You can get direct embodied carbon factors from what's called an environmental product declaration. So this is one of those hybrid method pieces of information. You can see the carbon factor right here. There are a bunch of ways to get average data if you don't want to call up suppliers. You can get some industry product calculators, like a paper calculator. You can find some aggregated carbon factors from lots of different software packages, but you have to be careful. For example, this one, Circular Ecology, it's an organization which has a great list of carbon factors, but they're specific to the UK. So if you didn't know that, you would misrepresent what's going on here in the United States. Or you can go directly to the source of some life cycle inventory databases, for example, our US Federal LCA Commons. Or you can just look for published studies for that particular item. On the spend-based side, there are also several different options. Some are specific to healthcare. For example, a tool that I've worked on is called the Healthcare Supply Chain Emissions Carbon Calculator, which you can all try out if you like at this website. Of course, there's also the Healthcare Without Harm Practice Green Health tool, which is for members and is here. There are also spend-based tools that aren't specific to healthcare, but you can use them and fill in information, and it can still be very helpful. So one that I really like is called the Qantas Scope 3 Evaluator. That's from the GHG protocol itself. So the people behind the GHG protocol helped with that development. There's 1,000,001 consulting companies with their own bespoke tools ready to help you if you'd like to hire them. And if you want to go straight to the source again, the actual raw data for doing this spend-based modeling, you can get right from the EPA if you're comfortable doing your own model. Okay, yeah, then you take your total list of materials and quantities and spend, you multiply them by your emissions factor, and you get your results broken down. This is from this healthcare carbon calculator I mentioned, and maybe a little bit tricky to see, but you can see surgical gloves over here, medical apparel and textiles. It's all broken down by the total amounts, and gives you a sense of what your largest liabilities are in carbon terms. Okay, I think I'll come back to this if we have time to discuss what the NHS is up to. On the capital goods side, there are a few more categories to go through, but they're all really fast. Capital goods essentially are just like purchased goods and services. You go through exactly the same steps. The only thing is you do not depreciate or amortize your emissions at all. You assign all of your emissions to the purchasing year. Right, so this is very different than the way you do financial accounting for these items. The other thing to remember is even if you put capital goods in a separate category here, you don't want to count the energy use or emissions associated with their use. That is scope 1 and 2 emissions. Okay, so be sure not to make that mistake. All right, next category is around transportation and distribution. This is actually broken up into 2 parts. Upstream from the reporting company, that's you as a healthcare organization, is category 4, upstream transportation and distribution. Category 9 is what's called downstream. And this is if you are simply getting products shipped to you and other people, other companies are taking products away. In the case that you as an organization are paying for either the incoming or the outgoing transportation and distribution, this is all included in category 4. All right, so how does it actually work for getting these factors? Well, you again have some different choices. If you know how much fuel you're using, this is the best, most accurate option. But often that's hard to know. So it's maybe more common to know exactly how far things are coming and going. So you use this distance-based method. Or sometimes you don't even know that. All you know is that things arrive and you spend money on their distribution. And so you can use this other spend method. After that, you collect the emissions factors. Again, I'll show you some examples. In the United States, I always recommend using the official US EPA emissions factors, and here's the link for that. Outside of the US, actually, there's a lot of different options depending on where you are. And the Greenhouse Gas Protocol, this guidance document, has a whole very large table that I won't go through to help you. And then finally, again, just multiply your activity data by your emissions factor, get your total. So here's a quick example. I'm here in Boston. Let's say my hospital takes 20 tons of medical supplies from a supplier in Minnesota, right? I have no idea how much fuel they're burning, but I know how far it is from Minneapolis to Boston. So I choose the distance-based method. It's about 1,400 miles. I go to that link I just showed you, and I get my US EPA emissions factor for CO2, methane, and nitrous oxide. Quick thing to note, these are expressed in different units, kilograms here, and then grams for CH4 and N2O. And then, yep, just do the usual multiplication, adjusting by the global warming potential of each of those gases. Right, so pretty straightforward. All right, last couple categories here, the processing and use of sold products. You might be wondering, what are these sold products? In my case, this doesn't necessarily make sense for me from a healthcare organization point of view. Okay, but there are some instances perhaps where, for example, people are going to your pharmacy or you have some kind of arrangement where you're selling healthcare supplies or devices to your patients. For example, cold chain medicines, if they're picked up downstream, they need to be kept cold. Metered dose inhalers, of course, when they're used at home by patients, there's the propellant emissions, and or, for example, an actual piece of medical equipment. In practice, this is very rarely accounted for by healthcare organizations, but I anticipate in the next few years there'll be more attention focused on this. And if you'd like to jump in, this is some examples to do so. So simply just collect information on sales of each item that you think applies to you in this category, and then just follow the scopes 1 and 2 guidance that you heard about for inhalers or for energy use and electricity for scope 2 that you talked about last time. All right, last category from my side is end of life. So this is waste management associated with those items that you sold. There is another category of scope 3 that you'll be learning all about next time called waste management. This is category 5, and you're just going to follow the same rules that you do for that. So in this case, you would estimate basically how much material is going to be thrown away and where it's going to go, whether it's going to go to incineration or landfilling, depends on the mix of treatment and disposal options in your location, in your region. And then again, go to the EPA emissions factors. There's a whole table of emissions per ton of different kinds of materials, cardboard and mixed waste and so on. So that's the high level guidance. I am gonna stop now and hand it over. I had to cover a lot of categories there, but hopefully that's a good overview for you all. And if there's time, I'd be happy to discuss some of the implementation at the NHS as well.
Thank you, Matt. Why don't we see if we plan to take questions? Is there anyone that has a burning question while this content is fresh for Matt on any of these items that he's brought to our attention? Type it in the chat. If not, I think we can move on to our next speaker. And I think we'll have some time at the end for Q&A, by which we can, maybe the best way to do it is we'll tackle both questions on carbon accounting and implementation at the end of all three of our speakers' presentations. So thank you very much, Matt. Great work. And thank you for demystifying and showing us the different ways in which we can account for all this really important information. All right, so next up we have Beth Schenk, who is Executive Director of Environmental Stewardship at Providence. And Beth Schenk has been working on the environmental impacts of healthcare for more than 30 years. And in her role at Providence, she's helping advance the organization towards its goal of becoming carbon negative by 2030. Beth is also an assistant research professor at Washington State University College of Nursing. She led the development of CHANT, climate and health tool, measuring health professionals' awareness and engagement with climate change and health. And CHANT has been translated into several languages and used in 30 nations. She developed for Providence the We Act framework, waste, energy, water, agriculture, food and chemicals, transportation, organize a range of action on environmental issues. And she's been active at the state and local levels, serving on the board of the Alliance for Nurses for Healthy Environments, as a treasurer for the state of Montana Health Professionals for a Healthy Climate, and as board chair for Climate Smart Missoula. She also hosted the Nurses for Healthy Environment podcast for 4 seasons. So without further ado, please take it away, Beth.
There, can you hear me?
Yes,
And can you see my slides?
you can.
And they're seeing them properly?
Indeed.
Okay, thank you very much. Thanks for that intro. I'm happy to be with you today, especially with this fabulous panel that I'm privileged to be alongside. I'm just going to tell you a little bit about how we're approaching this at Providence. First of all, just to make you aware of who we are, where we are. Large organization, 52 hospitals, 950 clinics, 28 million patient visits, et cetera. And we practice in these 7 Western states, which are fairly different from Alaska to Texas, but that gives us some of the richness in terms of how we can try making these changes in different settings, different geographies, different politics, et cetera. So in 2020, as you heard, we set this moonshot goal to become carbon negative by 2030. So essentially, we're doing all we can in this decade for all the reasons that you're all interested in this work as well, to transform our healthcare delivery so that it is at least closer to being planet safe. We're doing this across our entire footprint that I just showed you. And we are trying to use a data-driven, evidence-based approach that is measured by effectiveness. So more on that as we go through my slides today. As you heard, we developed the We Act framework. And what we are doing with this, importantly, is we have developed a scorecard. I'm going to be able to show you that next time we're together because we're tracking those elements more closely on the scorecard. But the general idea is that we track our resource use for everything that we can, the cost of that, and also the greenhouse gas emissions. We do this at each site. Right now, we have it live for the acute sites, 52, and we're working now on the non-acute sites, which is about 700 different buildings. And so that we're automating data to come into these fields on a monthly basis, straight from our purchasing or use or utilization data. So this is a pretty powerful tool. It gives us a whole lot more insight than we ever had. I have sometimes said it's like someone turned on the lights and we can kind of see what's going on. We have a blank section, not actually a section yet, but we have the intention of mapping procurement emissions for each site each month. But you'll learn, as I describe our experience, that is pretty much impossible today. That is still on our plan because, as you know, this is a huge percentage of emissions for every healthcare organization, and so we do want to capture that, and we'd like to do it using the same format that we are. So more on that later. I think of approaching our supply chain carbon accounting from these 2 different perspectives. One is the big picture, and that's sort of what Dr. Eckelman covered. How do we look at the entire breadth of an organization's emissions in Scope 3 in this case? We spend $8 billion a year on these categories. We want to have an idea of the whole, and the protocol does help us accomplish that. On the other hand, we're also brick by brick building our understanding from the bottom up by looking at specific projects that we can be much more accurate about and much more strategic about how we can reduce emissions. So I'm going to give you examples of both of those approaches today. So Dr. Eckelman showed you these tools. These are abundantly available online. And if any of you are going to spend time doing this accounting or you need to know more about it, you're accountable for it, you're working with a consultant, I recommend you take the Scope 3 course. I did that a few years ago. I refer to it frequently. I tap into those documents. I go and check what they suggested. And it's fairly complicated, I think. And so it's good to have a way to think about this and to kind of check your thinking on it. It's not expensive. It is kind of arduous and it's a little bit dated. I think it's from 2013 or 14, but still the principles apply. So I'm going to give you examples of what we're doing based on what Matt said. So the first 2 categories, I'm lumping them together, purchase goods and capital goods. They're not exactly the same, but they're pretty close. So as he indicated, the supplier specific method would be awesome, wouldn't it? It's the most definitive approach. It would be just great if we had product level cradle to gate data across our economy. We don't. Most businesses, vendors that we ask about it don't know. They don't know. They're where we are. They're struggling to figure this out too. So that's not going to be a solution for us. The second method, the hybrid method, does hold some promise for us. We've been able to partner with Microsoft for the past 4 years on our shared goals, I should say our parallel goals to become carbon negative. And partly because we're in Seattle, we have a lot of people who have kind of moved over to Providence from Microsoft. So we have this very nice relationship. And we've been able to really pick their brains about how they're doing this and what progress they're making. So they are essentially using this hybrid method. And they're in their first year, I don't have this exactly right probably, but they were aiming for 50% of their key vendors to understand their scope 1 and 2 emissions. This year, they're working to 80% of their key vendors. They're going further to help their key vendors reduce emissions. They're helping them with VPPAs and with planning and with on-site solar, et cetera. So we're not doing that, but we would like to use that similar approach to at least collect the scope 1 and 2 emissions data, collect what we can of other data. Microsoft has chosen a handful of scope 3 emission categories, the ones that you can control more, business travel, waste, commuters, to collect that data as well. And then for the rest to use secondary data, as Dr. Eckelman explained. So we are starting on this process now because the spend-based method that we began with is really not cutting it for us, but I'll get there. All right, the next one, the average data method that Dr. Eckelman talked about is really a lot more promising to us than spend-based just because it's based on math. So an example of this that's in scope 1 is our nitrous oxide. We directly can translate nitrous oxide to greenhouse gas emissions based on an emissions factor that doesn't change, based on the pounds of nitrous that we purchase. If we were going to do that using the dollars that we spent on nitrous, then we'd have to calculate an intermediary translation to say, well, then what is the emissions factor per dollar? And that dollar price fluctuates. So this is one of the problems with the spend-based method. It's not sensitive to the changes in the marketplace, like what a pandemic brings or what inflation brings. So these tools usually adjust for inflation, but it's not really quick enough for our purposes, which is to track change on a monthly basis or at least an annual basis. So we do hope that the average data method will become more available to us as we accumulate more knowledge about the mass of the products that we're purchasing. And this is something that all of us in healthcare can work together on to understand, okay, a pound of IV tubing, what does it mean? So this is a way that we can share knowledge and be a little bit more accurate with this while also not having to go to the specific suppliers each time, which is proving not to be terribly helpful. So the next slide just summarizes where we are. So we did a spend-based method for our 29 baseline in 2021. We're doing it again in 2023 using input-output calculators and using support through a consultant. So we have the number, we have the number that all of us are pursuing. It's a number. And it gives us basically the ballpark that we're all getting somewhere. Our scope 3 is about 80%. And for us, our supply chain and capital is about 45% of our total. So that's what others around healthcare are finding. Other than that, it's not terribly helpful for us, I would have to say. I mentioned to you what we're hoping to do and what we're currently doing with the hybrid method, and also our goal to really focus more on mass as sort of an intermediary step using that average-based method. These two categories of transportation and distribution also have their challenges. Fuel-based method, as Dr. Eckelman said, we're not going to get the gallons of fuel. It's just not going to happen. And distance-based method is great for a product, but we spend $8 billion. We have several thousand vendors. We have thousands of items, and they come from all over the world. Not practical. Neither one of those first two are going to be practical or meaningful. It will be such an estimate. So we end up doing a spend-based method, and that's what we have done. And I don't think it's particularly accurate either, but it is also pretty small in the scheme of things. So we're just accepting that number and not really doing a whole lot with this. However, we are working with our primary vendor, our primary distributor, I should say, and we meet with them and we talk to them about their efficiency. So are they doing what they can to decrease trips, to use the EPA smart way delivery methods of driving so that they're using less fuel, to move their own fleet to electric, and they are in fact in California already. So this is a good opportunity for us to work with them, for them to know that we're serious, that we appreciate what they're doing. But that's just a portion. They deliver about 40% of what we buy, and they're working on this in part of their area. So it's a step along the way. And then downstream, we don't count this as relevant to us, just like as Dr. Eckelman was saying about all of these products as well. We have looked at them in terms of what do we really sell, and this is specific to each organization, but in Providence, we don't have large pharmacies. We have some community pharmacies at our hospitals. We don't sell medical equipment for the most part, though we are involved with it. One thing of interest is we prescribe a lot. So we prescribe a lot of inhalers, for instance, a lot of CPAP machines, a lot of things that do take energy. But since we don't sell them or own them ever or have responsibility for them, we don't count them. This would be an interesting concept in terms of our influence. So our influence makes a lot of impact in terms of what is sold and purchased related to healthcare equipment. So we basically ignore this one, these three. All right, so there are challenges, of course, as we've talked about, with using the greenhouse gas protocol from this big picture up. And then next, I'm going to move to the bricks. The accuracy, as you heard Dr. Eckelman say, and me, it really depends on the emissions factors you use. It depends on your boundaries in terms of what the greenhouse gas protocol asks you to do for operational, financial, equity, et cetera. Our financial and operational pretty much overlap, so that's how we do it. Depends on your interpretation of the protocol. There's a lot of language in the protocol that says, well, do what you think is best, essentially. Apply this as you can. And you know, one of the things I hear people saying is, well, we're doing it this way and we're justifying it this way. So that doesn't mean we're all doing it the same, even though the tool is there for all of us to use. So accuracy is certainly a question. Accountability. So this is the one that I find the hardest to accept about the greenhouse gas protocol. And it's really that we all the steps along the supply chain, we count the same emissions. It's not that the distributor counts the distributor emissions and the manufacturer counts the manufacturer emissions and we count the user emissions. We all count them all. So I think this may lead to some problems with action. First of all, the complexity of the accounting for a complex organization like a single hospital, much less a $25 billion organization like ours, the complexity is daunting and it may stymie action. I hear this about people saying, well, how are we going to do it? What should we do? Is it worth doing? And then I think the lack of clear accountability based on that second section there can lead us astray. So for instance, I joke, I say, well, we don't have any scope 2 emissions because that's on the power plant. No, we don't have to worry about that because that's what the greenhouse gas protocol says in part. It also says we all count all. And then I think on the other hand, if we do count all, then it becomes this enormous challenge, an enormous number, and hard to really drive action on that as well. So I think these are some of the challenges of the greenhouse gas protocol from a user, someone applying this and really trying to make it actionable and also make it be an effective and sensitive enough tool for measurement that it helps us know where we are. Okay. Anyway, we have all this information and what do we do with it? And so this I'm going to shift now to really working from the bottom up. And I'm going to remind us of the principles of sustainable healthcare from the National Health Service. And these are some that we use. And it's just to point out what is clear when you think about it, that from top to bottom is most important and most impactful. The biggest thing we can do is keep people out of hospitals because hospitals are carbon intense environments. So that's the way to cut carbon. Patient empowerment is part of that. Helps them to take more ownership and do a better job with their own healthcare and to help us help them more. And then next is really making our processes efficient. So we want to work on that, and there's enormous possibility in healthcare because it's enormously wasteful. And those of you who work in healthcare will have good experience with that concept. And then last, find low carbon alternatives. Sometimes we want to race to the more recycled product, the less the more energy efficient product. And that's all really important. But there's a whole lot we can do upstream of that. And so we just remind us of that because one of the places that we spend a lot of our time is in that third one, the lean pathways part. So now I'm going to describe a few of those. So if we think about this, that one project at a time, we're trying to learn more about the specifics for that project and also how it informs the whole. We do emissions analysis and then a plan for reducing the emissions and waste and chemicals and cost in all of these different ways. So this is just a list of some that we brainstormed about earlier this week to see what various things we're working on or have recently worked on. Well, an analysis to understand the water, power, chemicals, and carbon related to our linen consumption, which is significant, a lot of linen. Most of ours is provided by a vendor, but we have about 5 live laundries across the health system. So that helps us then make decisions about, well, how much should we be using per adjusted patient day? So Dr. Cheesebro did, with an intern, did a life cycle analysis of linen, and then a nurse researcher in, that was in Portland, and a nurse researcher in Montana then did an application of a protocol on linen use and compared that across different units to see if that drove down use, and in fact it did. So by understanding the granular data of what are we talking about in terms of cost and emissions compared to process data of how do we use the product or the entity, then we can start to make progress and measure it. So that's great. Inhaled medications, again, looking at, and I think Dr. Sherman's going to talk about this today. I'm not going to go into detail, but just doing that analysis and understanding what informs then prescriptions, use in the inpatient setting, use in the outpatient setting, what instructions are needed, what education is needed for prescribers, what are differences in specific products or specific medications and how they're delivered. You know, we need to analyze that. It's pretty complicated. So we have done that through Dr. Cheesebro's work with our pharmacy team, and I believe Dr. Sherman will tell us more. Carbon intensity of meals. We're working on this through the Healthcare Without Harm School Food Pledge and also through our vendor, which is Morrison. They have a product called the Carbon Food Print. So we have set goals in terms of carbon intensity per meal, and we have methods to understand that. Embodied carbon in our construction. This has been something that is just, you know, it's just more recently for us becoming a practical tool so that we're able to look at in the building planning phase, not just for new buildings, but for remodel and renewals. Let's look at differences in steel, concrete, mass timber, et cetera, to understand what are we loading into that building at the front end. And it's starting to be incorporated into our decisions. This is a culture change thing, you know, and culture change is really where all this work takes us. But that's been gratifying because we have really committed real estate folks who are working on that and being able to inform these decisions through this additional lens of environmental impact. Leased vehicles. We're working on our owned vehicles and our leased vehicles. I just put leased here because that's scope 3. And as we are really racing, probably with the rest of the nation, toward our electrical vehicle strategy, this is happening fast, especially in California and Washington, where we have deadlines in terms of 2035. They're not going to sell internal combustion engines after that. So we are planning now and already starting to enact our electric vehicles for both visitors and for our fleets. Computer pattern management. We right this minute have 10,000 machines in a pilot to understand, can we really decrease carbon emissions, electricity use, informed by local emission factors, to understand how much we can really reduce just through a software addition. Reprocessed products, many of you use these. We've done analysis on these as well. I'll just cut to the chase on one product. It's Hover mats. Hover mats are intensely carbon intensive, partly because they're made of nylon. And that's work that Dr. Cheesebro has done with Medline Renewal, who is our vendor. These are examples, and these are all great and exciting, and you can really get traction with this because people in healthcare are kind of driven by this data. Give us the facts, show us, and then we can take that forward as we really enact the change. Okay, now the last one on the list here is surgical supply optimization, and I'm going to spend a moment here to describe this because it's really cool. So these two folks are the heroes behind this project. So Dave Wilson is a process improvement professional. That whole population of people brings such great skills. I hope if you're not using them now, you'll think about that. They have exactly what we need to make these efficiency changes. And Dr. Brian Cheesebro, who all of you know of, I hope, he's a marvel for the nation. And so they set out to solve this problem. So what's the problem? In surgery is very resource intensive and also prone to inefficiency and waste. If you spend some time there, you know that there's a lot of redundancy. There's, we're doing 20 air exchanges an hour, et cetera. Surgeons' preference cards, you may not be familiar with if you're not in hospitals a lot, but this is when surgeons say, I need this list of stuff to do my case. And so these are products, these are commonly used. But sometimes that means you bring in the same set of stuff for every case, and you may not need that in each case. So this inefficient, then you end up discarding them new. I sometimes say to people who aren't in healthcare, yeah, we actually bring in a whole lot of brand new stuff, open it and throw it away immediately. And we do. This is just astonishing. So this inefficiency leads to all these issues. New items are thrown out, sterilization, labor, and environmental costs. So they set out to solve this, and they've created a marvelous tool. So,
Okay.
yeah,
I was talking about that yesterday at Morgan's holiday party. How long it took for them.
I don't think that was my time warning, was it, Justin?
Sorry about that. You are at 20 minutes.
Okay, great, thank you. So this is really moving away from classic quality improvement. The work on surgical supply optimization relies more on process engineering and decision support tools. Why the Six Sigma process improvement person is so perfect. So getting the right supplies in the right place at the right time is surprisingly complicated in surgery and in healthcare, really. In the OR, the goal is to only bring in what supplies will be used clinically. Ideally, most of those supplies would then be reused, recycled, or reprocessed. That's above the line there. Below the line, these are the inefficient or wasteful processes with unused supplies either wasted directly, re-sterilized unnecessarily, or eventually expired. This is what we don't want to do. Our approach applies data to look upstream and during periods of clinical use, asking questions to develop an understanding of how inefficient or efficient the process is. What enters, what is used, what is wasted, what expires. In process engineering, we aim to operationalize these data to inform decision-making, as well as working to relieve clinicians of administrative tasks associated with managing these preference cards. So they have automated that process, operationalizing and automating. Finally, where clinician input is required, this data supports their decision-making with relevant and timely information. In other words, to decrease what's on their preference card, make it more efficient, make it more realistic with what they really use by giving them some feedback. So these are a few examples of some of the tools that are helpful in engaging clinicians on these issues. So on the right, we're looking at an analytic tool that consolidates performance and outcome data with respect to surgical waste. By waste, this is not everything that's going into the trash bins, but rather this is the tool that quantifies the surgical supply items that are opened, not used, and then wasted. Similarly, on the left, this decision support tool allows surgeons to compare the carbon intensity of their preference cards, supplies, and equipment with those of their peers. This has been a very effective tool, not only in this case, but also in the anesthesia reduction work by when you show how one practitioner compares to others, that usually gets their attention. So while we do track the financial impacts of these practices, it is clear that for most of our surgeons, financial stewardship is just not as personally resonant as their carbon footprint. This might be because we're along the West Coast, not sure. Our staff are usually pretty engaged in this work. And in this case, they really like to see how they stack up and how they might improve.
Hi, Beth.
So,
I'll give you your 2-minute warning.
Okay, thank you. So along these lines, with this tool, surgeons are able to open their supply equipment lists alongside their peers. So that's what's on the right. They can see, well, what is so-and-so using that I'm not? And then on the left, they can look head to head with other peers to compare their carbon impacts. So what does this translate into? Well, we have done this at two sites now. This is information from the first 24 operating room example in Portland, Oregon. And you can see how much was saved in each of those categories over time. So now we're in the process of automating this as much as possible in order to expand across Providence. Strategically, with such decision support tools, it's important to consider several of these issues. What this also scales up to, just so you would know, if we were to do this at all of our sites, and this is a rough estimate, it's about $40 million a year, 27,000 tons, metric tons of CO2e equivalent, 16 million kilowatt hours, 33 million gallons of water, and 210 tons of waste. So this is obviously something we want to do across all of our sites. And this is where change management comes in, because this is culture change. So this statement, this is my last slide, this seems true. We are surrounded by data, but starved for insights. And this, we have really put a lot of time and effort and continue to. It's really fun to translate the raw data that we collect, some of which is more meaningful than others, and turn it into action. So right now for us, the big picture, the spend-based estimation of our supply chain emissions, we don't have a lot of insight from that. We just don't. But by applying it to specific cases and developing better methods to assess our overall system-wide emissions, we begin to have and apply insights, which is the purpose of collecting data in the first place, according to our thinking, which is to drive action. Thank you very much.
Thank you so much, Beth. Wow, what great, tremendous insights. And thank you for sharing your story. We'll look forward to questions that people may have once we get to the end of the presentation. Up next, we have Dr. Jody Sherman, who is MD Associate and Associate Professor of Anesthesiology and Epidemiology and Environmental Health Services at Yale University. She's Director of the Yale Program on Environmental Sustainability, Medical Director of the Yale New Haven Health Center for Sustainable Healthcare. She's an internationally recognized researcher in the emerging field of sustainability and clinical care. Her research interest is in life cycle assessment and environmental emissions, human health impacts, and economic impacts of drugs, devices, clinical care pathways, and health systems. Her work seeks to establish sustainability metrics paired with health outcomes and costs to guide clinical decision-making, professional behaviors, and organizational management towards more ecologically sustainable practices to improve the quality, safety, and value of clinical care and to protect public health. We're very honored and pleasured to have Dr. Jody Sherman here. Jody, please take it away.
Thanks, John. Can you hear me okay?
Ken, yep.
Okay, let's see if we can get the slides to work. So I am at Yale New Haven Health System in Connecticut. It is the largest health system in the state, one of the largest in the Northeast, dwarfed by Providence but nonetheless, we have a sizable footprint. And while we're talking about carbon, it's I can't help but notice every time I look at the slide, you know, we also have to be measuring and looking at climate risk as we are all along the Atlantic seaboard. But this gives you a sense of the size of our health system. 5+ hospitals were rapidly growing, 200+ clinics, and our flagship hospital, Yale New Haven Hospital, is one of the largest in the country at 1,600 beds. And so today I'm going to be covering from our hospital's perspective, just a summary of total goods and services. I'm going to give some specific examples, diving into meter dose inhalers, a little bit on intravenous drugs, and just one example of a device, and that's a pulse oximeter. And so this is using the tool that Dr. Eckelman helped build, mapping our organizations across our health systems, emissions for goods. And I know, and I completely agree with Dr. Schenk that this sort of thing doesn't help with strategic management internally at the level of the bricks, as she described. That said, it is very important to help us understand something about the relative impacts of these categories, where the areas of interest are from a carbon perspective, and importantly, how we compare to other organizations. So, and importantly, this is something any organization can do now. So I hope to dispel the myth that we can't do a footprint assessment of our supply chain, because in fact, and particularly goods and services, because there are many tools out there, we can do it. Every organization can be doing whole organization accounting today. So those are our goods, these are our services, and again, you see sort of relative impacts, and they're pretty consistent or fairly consistent across our health systems, but importantly is that we are different size beds, and we're at capacity, so licensed beds, they're pretty much occupied every single day. Different footprint, therefore, but understanding, you know, the size and the relative impact, that's also not all the information, right? Because these are different types of facilities, they provide different services, and so how we normalize is really important. So looking at whole organizations are important to compare, to understand how we are similar, we're different, what organization, what hospital is performing well. And so when I look at my own institution, so The per CO2 emissions per dollar is interesting lowest for our largest flagship hospital. Our CO2 emissions per bed is very high here, but interestingly, this is a level 3 trauma center. This is a small community private hospital. I would argue that this one is not doing so well, but this is just based on our own internal data. When we have a large national data set, we'll have a better sense. And I think it's really important that healthcare organizations start with whole organization accounting. And this is just to show that top 20 detail ranks ranked by emissions dollars. You can choose how to do it. Again, to delve into those categories that are of interest. And I'm really glad that Dr. Schenk presented on surgical products because they're the top of the list. And similarly with services, these are how we rank them across our health system. And so this information, again, this is all doable from the same tool. This helps us take a deeper dive into the high impact carbon categories. I'm going to change gears now and delve into a specific example, and that is metered dose inhalers. This is probably something that most people are aware of as being considered a carbon hotspot in healthcare. The propellant used to be a CFC or in the Freon category that were phased out with the Montreal Protocol in the 90s, but was replaced with a very potent greenhouse gas. The propellant is what it dispenses the drug. If you've seen people use these inhalers or you use one yourself, a single short-acting beta agonist inhaler, one device is equivalent to about driving 200 miles. And we dispensed 55 million units in a single year in the US of just these propellant-based metered dose inhalers. The National Health Service, which has the best data analysis for a large health system out there, as you're probably all aware of, they've estimated that 3% of their health sector emissions come from these metered dose inhalers. So this is why they are a carbon hotspot. That, and it's a single type of thing that we can do something about. There are multiple alternatives to these propellant-based inhalers. They're called dry powdered inhalers, soft mist inhalers, nebulizers. There are different ways of distributing these medications. That said, they're not equal in terms of how they are, whether or not a patient can use them based on their health status, based on their education status. And so they're not equally interchangeable, but we do know, Sweden being an example, that they started this journey well over a decade ago. And so they're considered the leaders in this space. Their prescriptions are now 88% of these dry powdered inhalers. And so they've really set a benchmark. Now, is our population the same as that in Sweden? Probably not, but they have set a benchmark and an aspiration. And so taking a deeper dive, so we've heard about the top-down approach, and this story is very similar to that of inhaled anesthetics. We know quite clearly what the emissions factors are for the propellants in these inhalers. And so, yes, we can look at the plastic and upstream and downstream, but the propellants kind of dwarf everything else. So since we have precise data, we'll use it. And so we can use that to calculate total emissions from a hospital or a health system. Versus the top-down approach that Dr. Eckelman started with, or spend-based model. So different approaches, but if we can be more accurate about it, we should use the bottom-up approach. So we know how much propellant is in a particular device. There are tables out there. The companies provide this information. We know from our procurement records how much we buy. We multiply by the global warming potential, and that gets us to our emissions. And so this is what they look like across my health system. These are inpatient emissions from all of our inhalers. And again, I want to, one thing I just want to mention is that just because we substitute something that doesn't have a propellant doesn't mean that the emissions are zero. There's still emissions involved, and we have to account them. It's not it's not that we just make these emissions go away, we reduce them. So this is how my health system is currently performing. And again, understanding the size of the institution is important, as well as patient care demographics, but that gets a bit more complicated. So one question I want to raise is that these are considered scope 3. There's, supply chain, they're purchased pharmaceuticals. And I would argue these should be handled the same as inhaled anesthetics. And I think we were the ones that really said these emissions are directly coming out of a facility. They actually should be scope 1. So I would argue that inpatient use should be counted as scope 1. And for those that are used in the outpatient setting, we don't know how many are really dispensed. We can track how many prescriptions there are. And importantly, we can still intervene because we can educate our providers. But I would argue that outpatient prescriptions are scope 3. And in fact, that's what the NHS did. So they largely counted scope 3. And in fact, the outpatient dwarfs inpatient considerably. And I would also further postulate that if we are counting meter dose inhalers as scope 3, that we are responsible for as an organization, unless we're distributing the devices, we own our own pharmacies. For example, I presume, Kaiser Permanente would count them as part of their scope 3 directly because it's part of their organization. If these are bought and sold outside of our organization, I don't really think we should be counting the prescriptions, but we should be influencing them for sure. But if we were to count the emissions coming from our prescriptions, then we should do so for all the drugs that we prescribe, not just the inhalers. So, but moving on, and this gets back to what Dr. Schenk was saying. Really, we need to start by reducing unnecessary treatments. A lot of these are prescribed that, when they weren't needed to begin with, or they're no longer needed. So we need to do a better job, and obviously primary prevention. Choosing less carbon intensive treatments. There are a lot to choose from. It's pretty overwhelming, and obviously reduce waste. And I'm not going to be talking about this, but take back programs, which is an interesting way of trying to reduce the waste. Solid waste. I want to show some data from my own organization, and this is we've done detailed analytics looking at individual patient encounters, not average encounters, and really it is quite telling because we are able to ascertain that the vast majority of our inhalers are only partially used. And this has to do with getting into the human factors. And that, for example, that patients are moved between wards, and every time they're moved to a new ward, they are dispensed a new device. And so this is an opportunity for us to look at the institutional factors that contribute to that, to try and address that issue. There's another issue that we have, that patients are not allowed to take their inhalers home from the hospital. And this is just a tragic story of waste, given how expensive these are and how polluting they are. And that has to do with issues of insurance, issues of safety, issues of time and cost, because patients have to be educated. We have to make sure that they don't have multiple devices at home and are double dosing and so forth. So it's really, the change management piece is the really complex piece of it. The measurement piece is really the easy piece. So it kind of seems so simple. Well, we've got something that is much lower in carbon intensity. What's the big deal? Let's just swap it out. It really is very complicated once we start delving into the weeds. We also did a separate analysis, and that is looking at the number of doses that were used and wasted. So you see, we have a lot of documented waste of doses, and that's in the orange. And so I showed you some carbon data. This is some cost data. And so this is money being left on the table. It's not as simple as that, but the bottom line is, in terms of cost mitigation, this is just one hospital, in budget crisis, this is money being left on the table. But again, as I mentioned, swapping out is not so easy. So we have a couple of different types of devices and medications. So ICS, I apologize for not putting definitions there. So inhaled corticosteroid, LABA is a long-acting beta agonist, BID and QD, that tells us how frequently the drugs are administered. And so if we're going to swap out the first drug for a dry powder inhaler, it's great news is you only have to give it once a day instead of twice a day. But it is a lot more expensive. Now, if we look at swapping out that drug with nebulizers, this device has 2 drugs combined. So that means we need 2 different types of nebulizers. But it's a lot cheaper from a procurement perspective. And this is conservative. This is assuming round-the-clock treatments as opposed to as needed, conservative estimate for one hospital. And similarly, a different type of device, and this is a short-acting beta agonist. So that's one type of drug, and again, substituting with a nebulizer. So just to get a sense that there is money opportunity here, as well as carbon opportunity. That said, it's even more complicated than that because the nebulizers take longer to administer, so we require more staff. Everybody is burnt out, everybody is short-staffed. So does this fall in nursing? Does this fall in RT? We can't do it without our partners. And coming back to my own organization again, so I showed you, so our flagship hospital, this is what an annual emissions assessment is of our devices that are procured. And but I just want to point out one of our hospitals, this is Bridgeport Hospital, it's about 1/3 of the size, but the emissions are much smaller than 1/3. And it's not, yes, there are different patients there. In fact, I would say that is not the issue. This hospital in 2011, from a cost perspective, made the switch away from metered dose inhalers primarily to nebulizers. And this was taken on by, this responsibility to administer the nebulizers was taken on by a nursing staff. And they say, this is just what we do. So as we are struggling to implement and have culture change at our own hospital, we're looking to our exemplars, our nursing exemplars at Bridgeport Hospital. So I'm going to switch gears quickly, give an example of intravenous drugs. And this is something we've done in the operating room, looked at 20 common, I'm an anesthesiologist, and so 20 of the common drugs that we use in anesthesia. You're seeing this was a electronic health record chart review. And this was just over a 1-month period snapshot in our flagship hospital in one wing, typical adult anesthesia care. And these are the fraction of intravenous drug waste just from this setting. And in reviewing the literature, depending on the drug, 30 to 80% of these drugs are thrown away. It's on average 50% of all the medications we're using in the operating room are being thrown away on the anesthesia side. Could build a whole hospital for all we're throwing away. And even though this is an example from the operating room and just 20 drugs, the problems and the solutions apply to all intravenous drugs in all care locations. This is some work that we had done with Dr. Eckelman, and that was a detailed life cycle inventory or cradle to gate assessment of the active pharmaceutical ingredients of these drugs. So we could use the emissions factors from the spend base, or as Dr. Schenk was saying, to get more accurate, a lot more labor intensive, but once we know the emissions factors, we know them. And so these are the life cycle inventory emissions factors. So we can be more precise with what those emissions are, which helps to really drive behavior change and procurement change. And so just one hospital, just these 20 drugs, just one wing, throwing away $1.2 million annually. Conservatively, because this is just the active pharmaceutical ingredient, the equivalent of 22,000 kilograms of CO2, and then similar to driving around the earth twice in just one facility. So this really helps change ideas or motivate behavior change. And so why do we have so much drug waste? There's a lot of reasons for this. Oversized vials, there's been a lot published on this. They're made bigger than we need from, I would argue, from a business opportunity from the sellers. There's also regulatory issues to keep us safe, to prevent cross-contamination, make sure those drugs are still active. Obviously, there are real contamination issues. We can't get to zero waste, but we can minimize that waste. And over preparation, so that's to do on the behavior side, and setting up more than we need. And then the drugs do expire if we don't procure them properly. So one of the solutions that has been proposed for several years now is this idea of pre-filled syringes. On the left-hand side, you're seeing a manufactured, what's called a prefilled syringe that's manufactured, Bristol jets or Aberjets or some of the terminology. The packaging is really quite significant. The costs are quite significant. These are, but they have the longest shelf life, and these are the most expensive. So they really should be reserved for emergency use only. In the middle, what you're seeing is a third-party vendor. So essentially we buy the drug, we ship them to a third party, they split them for us into syringes or bags, infusion bags. And that is less shelf life than the first option, but much longer. If I just drop the syringe myself in the operating room, technically I have to throw it away within an hour. So this is a way to extend shelf life, reduce cost, reduce waste, and reduce pollution. And then the last option is this being done in-house by our pharmacy. That is a shorter shelf life because you essentially have to pay a lot of money to have it independently tested, but still we're talking this will last several weeks as opposed to an hour. So, and this has been shown to be better from a patient safety perspective. When we are preparing these medications ourselves, if we're diluting them, mixing them, drawing them up, we make errors. And so the safest way, in addition to the longest shelf life, is to have them prepared by pharmacy or directly at the manufacturer. And so this has been argued for well over a decade, for example, from the Anesthesia Patient Safety Foundation. This should be how we handle all our drugs. But we have to ask the question, do prefilled syringes reduce waste? We certainly know they improve safety. The problem is if you're just taking everything you've been buying and split it and put it out there, this is a real picture actually from the University of Utah when they started their prefilled syringe program. And this is all wasted, expired drug. This is what it looked like on a daily basis, because that's what it looks like when we don't have strategic management. And so we have been working hard to develop a software platform to strategically guide pharmacy preparation of these medications for us to maximize shelf life, minimize waste. This is a combination of looking at utilization of the drug types and quantities, so using the electronic health record, integrating with our procurement data management system. And so this is analogous to what Dr. Schenk was presenting on the surgical instrument supply side, management side. We're doing the same thing for pharmaceuticals. And so what you're seeing on the left is an example of insulin. These are the typical doses that we've seen utilized in the operating room in bolus format. And obviously 5 units is the most common that we use. When I first started at Yale, we got a 10 ml vial that we had in the operating room. It's highly concentrated, 1,000 units per ml. On average, we're using 5 units. So we're throwing away 99.9% of that drug because we cannot use it on another patient when we open it in the operating room, even if it's a multi-dose vial. At least in short order, I got them to downsize to 3,000 units, but again, we're using 5 units on average per patient. Then we got our pharmacy to prepare these bags, which work both for infusions and for the boluses. But again, this is 100 units. This dramatically improved our safety because it's 1 unit per ml. We have numerous medication errors, as does every health system out there, dosing errors. And this was actually motivated by, from a patient safety perspective. And now we're doing pre-filled syringes, 5 units per, which is exactly what we need to minimize waste. Now, there are more costs involved to have a pharmacy do this, but it is dramatically outweighed by how much we're throwing away in cost. And so this is,
I just want to let you know you're around 20 minutes.
thank you. I'm nearing the end. This is just an example. And again, as Dr. Schenk was showing, of a provider performance report of how I am compared in terms of how much I'm wasting versus how much my colleagues are wasting in terms of dollars, and integrating the CO2 as we speak. And as Dr. Schenk said, precisely, this is analogous to what we're doing with inhaled anesthetics, because there's the procurement side of things there in terms of environmental, preferably purchasing. There's the pharmacy management side of things and how we strategically minimize waste. And then there's the behavior side. And we can do this according to, it's complicated because we take care of different types of patients. And so it's a tool in refinement, but we can see how we compare to our colleagues, and this motivates waste reduction. One last example I'm going to give, shifting gear once again. This is an example of one device, just one device, and a common one at that, and that is a pulse oximeter probe. On the top left, you're seeing an example of a disposable one that has this like a Band-Aid type tape around it. The reprocessed disposable, which basically a third-party vendor will take a disposable and they'll replace that tape and they'll clean it up and send it back. And you get a certain number of reuses before it gets thrown away versus a reusable option. And of course, these have to be cleaned in between uses. And so with our students at Yale University and also with Dr. Ackelman, we did a life cycle assessment. And we did look at different waste management scenarios. I'm just showing you one, and that's incineration. But the story is all the same, that the per use, or in this case, we used 5 days as an average hospital stay, but however you slice and dice it, the reusable from it is far superior from an environmental perspective. And if we if we extrapolate across a year at our institution, this will say if we shifted our current practice of disposables, we have a mix of disposables and usables, but if we are primarily disposable, and if we went to reusables 100%, or not 100%, but mostly reusables, we would save a lot of carbon. And this is just one device, $4.4 million. And again, this is, looking by comparison, how we would approach the top-down spend base. But this is real money, and that's just one device. And we're just dripping with this opportunity all over the place. And just I will just conclude by saying, I do think whole organization accounting, even if it's not, it just helps identify hotspots, but helping us to compare institutions, identify, and then once people start on the carbon accounting journey, they'll be off to the races. But the future is manufacturer product level, life cycle, inventory emissions, the environmental product declaration that Dr. Ackelman presented. That should be mandatory on all medical devices. That should be part of the FDA approval process. We can make it happen. I think that really it needs to happen sooner rather than later. Our distributors can use that procurement data, also help us with the transportation data, and with their decision support tools. So, and they can help us, and they do help us track purchase drug, what's used, what's expired, what's returned. So those information management systems are already at our fingertips, and then the electronic health records, which show us utilization data and can have real live decision support tools. And this is patient data, specific data, provider specific data. This is really important to understand comorbidities, types of treatments again, so we can delve down and understand where the hot spots are, who's performing well, who's not performing well, how we do better. And a huge team behind all this. Thank you very much.
Thank you so much. And now I want to thank all three of our speakers for sharing their experience and knowledge, and giving us hope for all as we sort of walk down this path together, that we can share stories of success. Dr. Sherman just did, and we can all get there as a result more quickly. At this point, I want to open it up to questions. So I think the process that Justin has now posted in the chat, put your questions in the chat, or if you'd like to do it verbally, you can use the raise hand feature. If the questions are in the chat, we'll repeat the question so that everyone can hear on the WebEx.
Yes, we have a question from Andy Wumava. They are asking if you are able to answer how many numbers of devoted staff you have that are managing your respective programs.
Yeah, I think Beth should take the lead on this.
Um, let's see, 1, 2, 3. So there are 5 full-time people across our 120,000 employees. And then there are 3, I believe, part-time people. But that is not the full story, because our approach has been, this is part of everybody's job, just like infection prevention is, just like being compassionate is. So that's the culture change that we're depending on. We have excellent leadership support. We have wonderful communication support. You know, we have a lot of people who are on board, contributing, and really engaged. But that's on top of, but there are other work. But how we say this is, we want to change the way we do the work. It's not additional work. It's just changing the way we do the work. So you think of all the real estate people. This is, of course, part of what they do, but they're not specifically assigned, you know, to like a silo of sustainability, because there isn't such a thing. It's everywhere. But I'd say it's probably about 8 FTE across, you know, 52 hospitals.
Thanks for that. And I will say we've got part-time executive leadership and we have full-time analysts now. But as Dr. Shank says, it really is about making part of everyone's job. We have a health system level executive committee. We've got green teams with all department leadership represented at each of our delivery networks or hospitals. But it really is making it part of everyone's job. It really is about culture change and not additional to, but part of.
Thank you, Beth and Jody. We have another question in the chat from Yvonne Collins. As you begin this type of work, is there a best place to start?
I'm happy to jump in just on the getting started with the accounting and reporting side. The tradition has always been to start with scopes 1 and 2. Those are really under your direct control and are relatively easy to collect information about. Within scope 3, there's 15 categories, and some of them are easier to do than others. But my advice would be to try to do a overall spend-based analysis of your whole, whatever procurement data you can get. Right? If you can get all of it, that's great. But often that's not so easy. So then at least you'll capture the majority of scope 3, which we know to be this procured goods and services part. Now on the implementation side, I'm happy to hand it over to Jody and Beth.
You know, I completely agree with what Matt just said. I think everyone should start by just trying to do your whole organization accounting. And in terms of strategic management, I would say there are always issues bubbling up at every organization. So there are the high impact and the high feasibility, low impact, low feasibility. So you want to try and identify something for your institution that is high impact and high visibility. If you start with a whole level organization using spend-based, all organizations are interested in saving money. So you can get at that issue at the same time and really engage leadership around saving money and doing the right thing around carbon at the same time. That said, there are burning issues that are similar across every single organization. Every single one that Beth had on her list is on my list, and I'm sure is on most lists.
Yeah, and I would add a really big piece of, environmental stewardship work in general is engagement. We say engagement is the secret sauce, and that's getting people on board. And again and again, the 2 issues that come to the top of what engages people are waste and food. So those can be good places to try and make some impacts. They're not the biggest carbon impacts, but they have an impact. And I also think, as Dr. Sherman said, it's really great to get some cost savings on the books, because you're going to use that again and again and again when you try and tell your story and convince leadership.
Yeah, and just a follow up to that. Yes, the waste, meaning what we're throwing away, what's in front of us, that bothers everyone, because that's the visible portion. People feel very badly about that. I do want to take a moment and say that it means we have to move upstream for solutions. Everybody really wants to start with a recycling program, and it is so low yield and energy, human resource intensive that I would, I'd probably, I don't know, people are going to think bad things for me for saying this, but I almost think we shouldn't bother recycling until people get established programs, because it's a distraction from really focusing on what needs to happen.
Thank you all. There's another question in the chat from Joe Biogard. Was executive leadership supportive and on board to make the necessary investments in sustainability solutions from the beginning? And then for organizations that lack executive leadership investment, what are your recommendations to influence those leaders and gain necessary buy-in?
I mean, I will say it didn't, in my organization did not start from executive leadership. It really comes from the ground up, and every single program I know of that has started, to be quite honest, has come from nursing staff. And so really just being troubled by all the waste that we see and banging on doors and just trying to find a better way of doing things. Beth is in a different system. I think Catholic healthcare organizations are, because they are mission driven, they understand this is a moral issue. This is about doing the right thing. And so coming from, top down mission driven is a more effective way to get things started. Hopefully there's now enough momentum and awareness, and also wanting to avert risk that, accounting may be mandated. It's the right thing to do. Health organizations don't want to lag behind. They want to be leaders. So, if an organization is starting from scratch, I would personally, try and get in with executive leadership as a start.
Yeah, and I've done this work both with and without executive leadership, and it's much better to have it, I'll just say. But I think Dr. Sherman's right. It really starts from, it doesn't necessarily start there. I do think some common things that are persuasive. The cost is one, risk avoidance is another, especially now that we're really seeing impacts to our buildings and operations related to climate. I really think, when I think about Providence, having been at Providence for a long time, when we started to live with the fires was a real turning point for the entire West, but including our leaders and then it really moved up in the priority of like, well, of course we have to do something about this. That doesn't mean that it's always resourced at every turn, but it does mean that they help with planning and with messaging and with commitment, and it's enormously important. So I think there's a lot of different ways into that, and yet I still hear from health systems for whom it just falls on deaf ears. And I don't know, to some extent, because I'm pretty committed to this, as probably all of us are on the phone, that might be an opportunity to vote with your feet. I mean, I'm not saying you should leave, but I am saying, we, and as well as clinicians who are choosing where they work, that part of their decision can be, what are you doing, health system, about the climate crisis? So we have something to contribute in that regard too, though that could be controversial. Thank you.
Thank you. We have a hand raised. Kai Wang, if you'd like to ask a question.
Sorry, Justin, I'm an imposter. I'm not Kai, I'm Seema, but I'm just using her login. First of all, I just want to thank you all profoundly. And I want to say that many of us have built our careers on the work that Dr. Sherman, Ackelman, and Beth have done. So thank you very much. And if I could just echo Dr. Sherman's comment about recycling and downstream, I think that, to anyone starting, that's very, very relevant to focus upstream. But my one question from an operations perspective is, how have you engaged infection control on a lot of these things that you want to achieve? And the second thing is, I know that Dr. Sherman is working on a policy level, and what is happening on policy level to sort of change some of our practices and behaviors, or at least get health systems to think about it.
I would say infection control needs to have a seat at the table and be involved when we're talking about pharmaceutical management, we're talking about medical device management, particularly when we're trying to shift away from away from disposables back to reusables. And you can't do it without them. And it also takes a lot of education and teamwork and partnership because the historic goal has been zero harm, zero infection rates. That's everybody's goal. That is a laudable goal. We also know it is not realistic, and that the two most important factors that we know of globally has to do with we have to do a better job of washing our hands, and we have to support our patients' health status, patients who are immunocompromised. We can't solve those issues by throwing more and more disposable devices at the problem. So it really is about educating our infection control colleagues and having them at the seat at the table. And I'm starting to see they are turning around, but the idea of zero harm as the goal really needs to be changed to minimal harm. And they're not the same. When our eye is only focused on the zero harm, it becomes at the expense, or it's always the excuse. Well, we're going to stay with disposables, even if it's more expensive because it's safer. And in most cases, that has not been proven to be true. So we need a more rational approach. Not that everything should be reusable, but many things can and ought to be reusable. Beth, I don't know if you care to add to that.
Well, this is often a point of, I wouldn't say friction, but it's definitely a point. I've said, to friends, kind of behind the scenes, make sure you make good friends with your IP team to do this work. So you have to establish those relationships, but more, scientifically, we can treat this also as an element of harm. I mean, the work that Dr. Sherman and Eckelman have done to measure the harm of healthcare pollution. When we think about the plastics themselves, that too is an element of harm. So when we want to be harm-free or avoid all risk, this is a piece that we need to bring into the equation. What is the risk of actually creating the carbon emissions and the plastics and the waste, et cetera? What we're doing in Providence, we've been working on it a couple of years, and I will say it was slowed down by the pandemic, and this question was made more complicated by the pandemic. So we have to recover with a rational approach. But what we're doing is beginning our Environmental Stewardship Clinical Alliance, and it's really to work with leadership at first, because there's a lot of grassroots going on, but working with the leaders of our key divisions, medicine, surgery, nursing, pharmacy, infection prevention, to be able to work through some of these issues together. I think this is a very exciting area that the whole nation can contribute to, and we need case studies and we need data. There really still aren't that many. I mean, when you start to go look for a good solid case study, there are some, but we need them to be more robust, because these decisions are really, they're going to be very cautious.
Yeah, and I just adding one more thought to that in response to your second question around policy, I would say, well, first I just want to come back to education is really not only of our infection control colleagues, but of all our clinical colleagues who, many of which are, under the misimpression that something is safer just because it's disposable. We can cross-contaminate with something that's disposable just as easily as we can with something that's reusable. And so we really have to dispel the notion that just because something's disposable, it's better or safer for the patient. So it is a constant education. And the other thing I would say is that through the National Academy of Medicine, are really quite delighted by the leadership of Dr. John Perlin, who's the new head of the Joint Commission. He is very committed. One of his strategic priority areas is environmental sustainability. And while the Joint Commission and other accreditation bodies, they're tasked with holding us accountable to our own policies and national policies, namely coming out of the CDC, to have accredited organizations. They recognize that there is an opportunity for them to develop measures and metrics around making things more sustainable, and have a whole task force working on that now. So really delighted by that, because education being one issue that drives a lot of this disposability in hospitals. Another driver is fear of citation by accreditation bodies. if there is the perception of something being of increased infection risk. And so that fear of citation will drive organizations to throw things away to avoid potential citations. So that's another thing that the Joint Commission is looking at. And so really exciting about the changes that are coming.
Thank you. We have another question in the chat from Andy Wumova. How do you go about selecting the platform, aka software tools, to manage your scope accounting?
All right, I answered that one in the chat also, but just to say it out loud here, my whole consistent strategy is to try to get as close to the EPA official factors as you can. And that means either using them directly or using a tool that's directly linked to them. And it's important that, that you also use the tools that are available through the GHG protocol. The protocol website has a bunch of different calculators and spreadsheets and guidance. There's a lot of resources available through the GHG protocol site that are there to help you. So I would start with those tools. They have the benefit of being free also. And I think you can calculate a lot of scope 3 categories using those and simple things, just Excel and so on. For goods and services, though, it's definitely more involved. And so that's why we've been working on making some free software that's easy to use and handles the complexity of that category. Yeah, so there are a couple options, and I expect that several more will pop up as this initiative really gets rolling here in the United States.
And I would add that, especially for large health organizations, for small facilities, small operations may be working mostly by spreadsheet, which is much more challenging, of course. Large organizations have the benefit of distributors, data analytics platforms, and electronic health records. But I think probably, as Dr. Schenk was presenting, the larger health organizations are putting resource behind integrating those two because they see the opportunity for strategic mitigation management, both cost and also carbon and other pollutants as well. So that's the benefit of being a large healthcare organization. For smaller ones, that I think the best we can do is do the best we can to share freely, and not just for small ones, but to make whatever resource we can available for free to help lift everyone up in this movement.
Are there any other questions for the speakers? Okay, I know we have a few more minutes, and Matt, I know you skipped over some of the work that you had done or that NHS was doing, and we do have a few more minutes if you want to speak to some of that.
Yeah, sure. Thanks, Justin. I'm happy to do that. Let me just share my screen again then. And to find it. Yeah. Okay. Yeah. So as was mentioned, oops. Sorry about that. Let me try one more time. All right, here we go. Yeah, so as was mentioned, I spent probably a year or two working with NHS on their supply chain side, and the story was very similar to what you heard from Dr. Sherman and Dr. Schenk here. They had a top-down understanding of what they were liable for in terms of their overall emissions. And then they really dug into those different categories that they knew were large, and they tried to figure out, well, what can we actually do on the food side, switching to plant-forward diets. They knew what the baseline was, and they said, well, I'm going to go to this other piece of information. I'm going to dig into this category and worked with my vendors to understand the total amount of beef in mass terms that they were buying. And then they said, well, if we can find, plant-based alternatives or, plant-forward diets that can be substituted in or incorporated more into menus, they then could use that information to look forward and see, well, how much can I actually get for that substitution? And if I try to make different efforts on operations that I control, these so-called demand-driven actions, how much can I actually reduce? Can I get to zero? And the answer was definitely not. Right? And then they said, well, what can we do with the remaining more than half of emissions? Those are really things that we have to address with our suppliers, and to have joint programs and make joint goals with them around decarbonization and engage them in the ways that you've heard about already. One of the other things that I thought the NHS did very well is they coupled all of their actions, each of those implementation actions, with some outreach. And they put together these guides that they then distributed all over the couple hundred trusts that they have within the NHS in England, specifically about how to actually make this happen. It's one thing to look at the size of the opportunity, but this is a very distributed, all hands on deck effort, and many people just aren't trained in this sort of thing and just don't have the mindset that it's important. So having these how-to guides, coupled with some really good educational campaigns, this has been very effective for them. So we don't have that many minutes, so I'll just stop there.
Thank you, Dr. Eckermann. Well, I'll pop back in. I really want to thank all three of our speakers, Dr. Eckermann, Dr. Schenk, and Dr. Sherman, for sharing their experience and answering questions. And all you attendees, thank you for attending. The only way that we're going to make progress on this is by holding events like this, sharing what we know, and organizing collective action. So thanks for attending session 2. We look forward to session 3 on January 26th. Hope you all have a wonderful holiday season and Happy New Year. And excited to continue this challenge next year. Thanks, everyone. Take care.